Good afternoon. This case is being presented by Department of Surgical Disciplines, Surgery Unit 1. This case is being presented by Surgical Disciplines, Surgery Unit 1. Vomiting and abdominal pain is not common in emergencies or in our clinical practice. But when such a case comes, we are unsure about the diagnosis and will have to take support from different departments to actually settle this case and give final management. So we have multidisciplinary teamwork to deal with this case, and also the fact that with symptoms that he has come, we could not arrive at a clinical diagnosis. We just had some broad classification. So I invite Dr. Irfan to give the case details, followed by Dr. Ankita to give the review of literature, and from Dr. Surabhi's team, radiology, to give the radiological assessment, and gastroenterology department, who played a very important role in management, Professor Pramod Garg sir and Dr. Ashish will be giving their details in between. Dr. Irfan, please.
Good afternoon, everyone. An unusual target in an adult. Our patient, a young gentleman aged 23 years, presented with the chief complaints of recurrent vomiting for the past 1 year and associated with upper central abdominal pain for the past 1 year. The vomiting was non-bilious in nature, non-projectile, 3 to 5 times per day, lasting for 4 to 5 days. There were 1 to 2 such episodes per month. The vomiting was immediately following oral intake, which the content was undigested food particles or water. It was relieved in fasting state. The abdominal pain was colicky in nature, moderate to severe in intensity. It was relieved spontaneously. However, it required injectable analgesics sometimes. The patient also gives a history of associated decreased appetite. There is no history of any hematemesis, altered color or consistency of stool, fever, itching over body. There is no history of any significant weight loss. There is no history of any previous abdominal surgery. The family history is non-significant. In the examination, the general physical examination, it was apparently normal, and in the systemic examination also within normal limits. So we have come to a provisional diagnosis of a gastric outlet obstruction, likely of a benign etiology. The cause is to be evaluated. In the lab investigations, the CBC, RFT, LFT and the coagulation profiles all were within normal limits only. And I would like to invite Dr. Naren, Senior Resident from Department of Radiology, to describe the imaging findings in this patient.
So we have the chest X-ray and the abdominal X-ray erect view of this patient. The chest X-ray was normal. There was no evidence of pneumoperitoneum that was seen. In the abdominal X-ray, there were no significant dilated bowel loops or air fluid levels that were seen. But one finding that was that the transverse colon was displaced inferiorly by probably the gastric shadow. So with the history of gastric outlet obstruction, this could probably be the stomach that is causing mass effect on the transverse colon. So the patient had a CECT in which oral contrast was also given. In the CECT, you can see that the stomach is grossly dilated, and the duodenum first part is also dilated. And as we further go down, there is a polypoidal structure which is kind of giving a targetoid appearance with few vessels that are traversing through it. So this is better seen on the coronal and sagittal reformats, where we can see there are few vessels. There is intussusception of a part of a bowel loop into the duodenum with a likely hypoenhancing hypodense structure at the lead point. There is also presence of mild central IHBRD that is seen on these images. So with this kind of a targetoid appearance and vascular vessels that are supplying with a hypodense lesion at the lead point, the radiological diagnosis was a duodenal intussusception with likely a polypoidal lesion at the lead point.
Thank you, Dr. Naray. So we admitted the patient with a provisional diagnosis of gastric outlet obstruction due to a duodenal lesion, likely a polyp, with a duodenal intussusception. We carried out an upper GI endoscopy, which showed a large sessile polyp involving more than 50% of duodenal circumference at D1 D2 junction. The rest of the D1 D2 mucosa was normal. We also carried out a colonoscopy to rule out any colorectal polyps, which showed a normal study. The biopsy from the polyp showed a tubular villous adenoma with a low-grade dysplasia. So we have confirmed the diagnosis for duodenal tubular villous adenoma with a duodenal intussusception. And plan was made for an endoscopic guided piecemeal polypectomy under GA due to a larger size of the polyp, and the patient was keen on in minimally invasive procedure. During the hospital stay, patient developed acute pain abdomen with multiple episodes of vomiting and upper abdominal distension. Opinion from gastroenterology was sought again, and patient was further managed by Dr. Pramod Gargan team from the Department of Gastroenterology, and I would like to invite Dr. Ashish fellow from gastroenterology to discuss further plan and course of the patient.
So on 14th, this patient was referred to us with acute onset abdominal pain and recurrent vomiting. We did an endoscopy for this patient. In this video, you can see that we are in the second part of the duodenum, and at 12 o'clock position, there's a polypoidal growth which is causing luminal narrowing, and we with difficulty were able to negotiate the scope across the narrowing. And once we had negotiated it, the duodenum was significantly dilated, and you can see that beautifully that there's a very large polypoidal tumor that is present in the duodenum and which is prolapsing into this distal part of the duodenum, and the duodenum is significantly dilated, likely related to recurrent obstructions. Now the problems with the polyp was that, first of all, it was a very large polyp, almost a sessile polyp. We were not really able to visualize the base of the polyp. It was likely wide, and it was located in the duodenum. Other issues were that he was very young, 20 years old male, and surgically to remove it, it could have been a major surgery in this patient. So we planned for an endoscopic resection for this patient. The endoscopic resection was performed under general anesthesia. You can see that here we are performing an endoscopic resection. Piecemeal resection we are performing. We are cutting it down with the help of a snare and reduced it in size. So in the first endoscopy, like this, we were dissecting it out. In the first endoscopy, over a period of 1 hour of endoscopic procedure, we removed around 60% of the polyp. But the problem now was that significant part of the polyp was still left, and the polyp was having a very wide base. It was almost a sessile polyp, and there was a risk of significant bleeding and full thickness resection if we went ahead with the resection. So what we did was we applied an endoloop at the base of the polyp. What is an endoloop? It is a plastic loop which we apply at the base, and we tighten it so that it will prevent the bleeding from the vessels which are supplying the polyp. And then we planned a repeat endoscopic resection in the OT itself, so that if there is any complication, we would have surgical support. So here you can see after 4 days when the second endoscopy was done, although we have removed a significant part of the polyp, still a major portion of the polyp is left, and it is occupying almost the entire lumen of the duodenum, and it is causing narrowing, and the loop is still there in the place. So we went ahead with the endoscopic resection again, and here we resected almost the entire polyp again over a period of one hour. But as the endoloop that we had applied earlier, it had entrapped the muscle layer. So when we were dissecting through the base, there was a full thickness resection at the base of the polyp, and so we handed over the patient to the surgery team for management of this resection.
Thank you, Dr. Ashish. So, as there was a perforation seen through the lumen during the endoscopy, the surgery team took over and did a duodenal perforation repair with a feeding jejunostomy. We opened the abdomen through a cochlear incision, cochlearization of the duodenum done, and the residual polyp were excised and perforation margins were revised. The primary repair of the perforation done using a PDS 30, which was superimposed with a omentum, and feeding jejunostomy was done 20 cm distal to the DJ flexure. Here you can see the duodenal perforation repaired with a absorbable suture and omentum was superimposed above it. Post-operatively, the patient tolerated the procedure well, and we started on oral liquids 1 week later and gradually increased the oral intake. The patient was discharged 2 weeks later. In the follow-up, patient has been symptom-free, and the final histopathology showed features of tubular villus adenoma with low-grade dysplasia. There were no evidence of any stalk invasion. The surveillance endoscopy was carried out 2 months later, and it showed a hyperemia and edematous mucosa in the stomach fundus with a few erosions suggestive of fundal gastritis. The duodenum was normal and was healed well. There were no residual polyps. And I would like to invite Dr. Ankita, senior resident from Department of Surgery, to review the literature.
Thank you, Dr. Irfan. Bowel obstruction in adults due to intussusception is a very uncommon condition, and it is seen in up to 2% of cases, of which small bowel intussusception is further rare, and duodenal intussusception is extremely uncommon owing to its fixed retroperitoneal position, which is attained during embryological rotation of the gut, thus making intussusception possible only if there occurs a malrotation. However, this was not the case in our patient. And secondly, these are again rare because the duodenal tumors which leads to these intussusceptions are themselves rare. The first described case of duodenal intussusception was given by Sunderland in 1930, and the true duodenal intussusception are rare. The true incidence is not really known. As you can see in this pictorial representation, the intussusception is defined as the invagination of all the walls of the bowel, proximal bowel, invaginating into the distal wall, which in our case led to obstruction. Thus, there was a proximal dilatation and retention of the intestinal contents, leading to gastrointestinal obstruction. This entity needs to be differentiated from mucosal prolapse, which occurs as a result of the weight and slippage of the mucosa due to a duodenal tumor. As we can see here, the mucosa is hanging. This entity is at times mistaken as duodenal intussusception. In adults, the cause of in adult intussusception, the overall cause is idiopathic in approximately 20% of the cases. However, in rest of the patients, there occurs a lead point. In duodenal intussusception, these lead points are duodenal lesions, which are broadly categorized into subepithelial lesions, which can be either lipomas, gastrointestinal stromal tumors, or neuroendocrine tumors called carcinoids. They can be mucosally based lesions as well, which can be Brunneroma, which is Brunner gland adenomas, or polyps associated with Peutz-Jeghers syndrome, or they can be adenomas, which was the case in our patient, which was a non-ampullary variety. These adenomas are generally incidental findings, which are found while doing routine endoscopy in patients where symptoms occurs due to some other cause. And the prevalence on routine endoscopy is low, which is less than 1 to up to 5%. Adenomas are most frequently encountered polyps in duodenum, and sometimes they are associated with genetic syndromes like familial adenomatous polyposis or Peutz-Jeghers syndrome. The sporadic duodenal adenomas are further rare. The estimated prevalence of non-ampullary adenomas is less than 0.5%, and for ampullary it is between 0.04 to 0.12%. Biopsy for histopathological confirmation is recommended, and due to their malignant potential, which is more so for ampullary lesions, the resection is mandatory. However, it is challenging for duodenal lesions because of the low caliber of the duodenum, the thinned out wall, and the presence of ampulla, which is a complicated condition. The patients who come with this condition, their diagnosis is generally delayed because of the long-standing intermittent and non-specific symptoms with which they present, and most of the cases are diagnosed at emergency laparotomy. This condition is a radiological diagnosis where we have the finding of coil spring sign. This is the enteroclysis image taken from a case report where this patient had a duodenal intussusception with a filling defect, and this sign occurs due to the fact that the contrast reflexes between the lumen of intussusceptum and the intussuscipiens. Then we have the target, the unusual target, which was the cause of gastric outlet obstruction in our patient, which is synonymous with donut sign or bullseye sign, which is seen both on ultrasound as well as on CT. This was the CT of our patient. There is another sign seen on ultrasound when the bowel is seen longitudinally. It is also called hay fork or sandwich sign. Other modalities available for diagnosing these conditions includes endoscopic ultrasound, which is required for the staging of the local tumor and are generally reserved for lesions which are more than 2 centimeters or are suspicious of cancers. CT or MR enterography have the obvious advantage of better bowel enhancement and the lesions arising from it. Upper GI endoscopy is an essential part of diagnosis, as they diagnose the morphology as well as are essential for obtaining a biopsy for histopathological diagnosis. Sharma et al. Have emphasized the value of visualization of fat planes between the bowel walls so that the true intussusception can be differentiated from mucosal prolapse, which occurs due to these duodenal tumors. Most of the times, the duodenal adenomas are asymptomatic. However, if symptoms at all occur, patient can present with dyspepsia, abdominal pain, overt gastrointestinal bleeding, or sign and symptoms of anemia, bowel obstruction, or rarely intussusception, which was seen in our patient. When duodenal adenomas present with intussusception, patient have also presented with complications directly, which can be complete or partial bowel obstruction or the sequelae. There are some case reports wherein patients have presented with intermittent biliary obstruction, which should be more common with ampullary duodenal adenomas. However, it has also been seen with non-ampullary lesions as well. There are few case reports where patients have presented with acute pancreatitis and chronic pancreatitis as well. Duodenal intussusception, when occurs due to duodenal adenomas, they warrant intervention due to the obvious malignant potential of duodenal adenomas. The intussusception can be reduced endoscopically, laparoscopically, or even by open surgery. However, surgical resection without reduction is conducted for the patients who present with complicated intussusception or if primary malignancy is suspected. For duodenal adenomas, minimal invasive approach like cold snare polypectomy for lesions less than 10 mm size, argon plasma coagulation ablation, or piecemeal endoscopic mucosal resection called mucosectomy for larger lesions are being done. Ampulectomy, or better called endoscopic papillectomy, is done for lesions found at ampullary region. Either can be done by a snare or electrocautery. The surgical procedures which are being done for this condition includes polypectomy through enterotomy, limited duodenectomy, ampulectomy, and Whipple's procedure as well. It has been seen that patients who present with duodenal or ampullary adenomas are at increased risk of colorectal neoplasia. Thus, according to American Society for Gastrointestinal Endoscopy guidelines, a screening of all of these patients with colonoscopy is recommended. Post-resection surveillance, there are no fixed guidelines. However, most of the authors, they favor a short-term follow-up through endoscopic surveillance in 3 to 6 months post-resection, which generally includes a post-polypectomy scar biopsy. And if at this time there are no residual or recurrent neoplasia found, another surveillance endoscopy generally planned at 1 year, which would be done in our case. Now I would like to invite Dr. Anita Dhar to conclude the session.
To conclude or summarize, I should say the duodenal adenoma with duodenal intussusception is a challenging condition. In our case, our patient was young and he was very keen for endoscopic management only. He primarily didn't want any surgery. Looking at the size of the adenoma, he was very keen and he wanted to have it like that. Preoperative clinical diagnosis, as we have seen, it was not of much importance in this to give us a final clue as to what we were dealing with, except for we made out that it was a gastric outlet type of an obstruction. Endoscopic management is well established. We have with us Professor Pramod Garg sir. He will give us some comments on it. Surgical treatment should be reserved for larger size tumors, adenomas, severe dysplasia, suspicious carcinomatous infiltration, recurrence after endoscopic resection, and if it's associated with complications. I'll conclude this case, and the case is open for comments, and questions. And we have Professor Pramod sir here, and I'll request him to give his feedback.
Managed it pretty well and very supportive during our attempts to remove the polyp endoscopically. More often you find surgeons will say, no, you can't do it, just let us do it and take it out. So they said, no, you persist with it, try and remove it. So I must appreciate that. Now, the couple of things in this patient, one is that isolated duodenal adenoma is rare. Most often we find adenoma in the colon. So colonic adenomas and polyps are very well known, and we encounter them almost on a daily basis and remove them endoscopically, not a problem. Second is, a patient was very young, he's only 23 years old, but there was no family history of polyposis coli or any other polyps or early cancer in the family. So that is second thing which is unusual, that you need to generally have, in a young patient like this, we would expect some family history or other polyps elsewhere. And that is the reason why this patient needs proper surveillance to find out there is a recurrence of polyp either in the small intestine or in the colon. The timing of surveillance would depend, maybe we can do it at a year's time to see any new polyp coming up. The third issue is about the management. So if you have a pedunculated polyp anywhere in the colon or in the upper GI, it's rather easy to remove because you can just clip it or put a loop like we did here and remove the polyp. There are no chances of bleeding or perforation. The problem arises in patients who have got a large polyp with a wide base which is sessile, not pedunculated, like this patient. So we actually debated quite a bit whether we should go ahead with endoscopic resection or straight away the patient should go for surgery. One of the concerns the surgeons had that whether it is very close to the ampulla, papilla vater or not, or arising from there. If that is the case, they might sometime end up doing a Whipple's rather than a polypectomy. Or they might have, if you have to remove part of the duodenum, then you end up doing a Whipple's, right, which is a rather big procedure for this. So fortunately the papilla here was spared. So because of patient's preference, we thought, okay, let's try and do endoscopic resection. So after the first resection attempt, we thought we have removed about 60–70% of the polyp and we should be able to do it complete resection the next sitting. So we applied an endo loop, as Ashish told, to prevent any kind of bleeding, because there seems to be a large vessel going into the base of the polyp on CT if you saw that. So next time when we were removing it, we removed most of it, and when we finally removed it, we realized that there is a full thickness resection. So nowadays one of the techniques to do endoscopic resection is full thickness resection. You actually remove the entire polyp, so there is a defect in the wall, and then you suture it up. So nowadays we have suturing devices also available, endoscopic suturing devices. We don't have it, it's not very commonly used, but I think over a period of time we should have that device. So other than that, there are some clips available with which we can close the defect. But in this patient we found that the defect was slightly larger because of the wide base of the polyp, and we thought it is better that to be sure the patient was in the OT that actually they do a proper surgical repair. And that is what was done. One of the advantages of doing a full thickness resection is the chances of recurrence now are very, very less, very minimal, because the entire whole area is now resected. So that is it. So overall, I would say that again that you managed pretty well. We could have succeeded without surgery if there was no full thickness resection. But in retrospect, I think it is fairly okay. I'll be happy to answer any questions. No, so it's a large polyp. So in small polyps, particularly those who are very, very superficial, one can do some kind of either cryo or a laser or a argon plasma coagulation burnout of the lesion, but not large polyps like this.
Thank you, sir. May I request Dr. Surbi, since as was highlighted, this radiological diagnosis in the beginning itself, we had no clue. Patient has intussusception and patient has this adenoma. So I'd like her to give some comments.
Actually, this case radiologically was a textbook appearance of, So the first finding that strikes our eye is the massive gastric dilatation. Okay, so this is the stomach which is massively dilated. The first part of duodenum is dilated. Then we have a typical target appearance that is seen in the second part of the duodenum. and in which the center of which is what is the fibrovascular core. So where we can see the enhancing vascular channels and the associated surrounding hypodense structure. So this is the fibrovascular core of the polyp. This is causing dilatation. There is no stalk. Sometimes on imaging we can identify a stalk. Most of the times we are not able to identify unless it is large enough. But otherwise this is a textbook appearance of what a polyp causing an intussusception would look like. In the coronal again, so this is the fibrovascular core. So where we can see the enhancing vessels and the interstitial substance. This is the entire polyp. So this is the entire polyp, and this is the infolding of the wall which is causing the intussusception. So these are the typical features.
In that stalk, do you find that the entire wall of the muscle is also going inside?
So not in the, so this is not.
When you are showing that it is actually going inside.
Yeah, so yes sir, yes sir. So this is the one, yeah, this is the entire wall. So we can see actually all the walls of, had it been just mucosa,
Because that explains why when we did apply the endoloop,
the wall was breached, yeah.
So we were a little concerned why it has happened. Now,
Yeah.
let's explain.
So actually, it has been just a mucosal intussusception, which is interning. So we would be seeing a enhancing mucosa. Here we can see a hypodense layer, which is actually reflects that the entire wall has gone down. So these are textbook appearance and should be kept in mind by everybody. Thank you.
Thank you, Dr. Surbi. May I request Dr. Prasandeep from Pathology Department, he is with us. Since it was a very straightforward diagnosis from them, but I'd like him to comment.
Thank you. And the case has been covered very well, and as Professor Garg has highlighted, single adenomas in the duodenum are very rare and they are mostly associated with polyposis syndrome. But in 30 to 40% cases we can see the single isolated adenomas in the duodenum also. They can be associated with Crohn's and celiac disease also. One thing is, apart from these non-ampullary adenomas, this is the intestinal type which shows more malignant phenotype or more features of malignancy. We can often see the pyloric adenomas also, that sometimes may be important. And in this case, this was removed in piecemeal, but if it can be snared off or snared out, then it is always advisable to give us a good mucosal margin and pin it on the basically a piece of basically thermocol or something, because there is a typical, because this is a large polyp which is more than 2 centimeter, and there is always chance of having high grade dysplasia or at least in situ carcinoma or invasion, because there is a specific protocol of Haggett's classification we do for malignant polyps. So always when we are dealing with this type of polyps, so we have to get specimens which are pinned and with a adjacent mucosal margin. So that we have to keep in mind. Thank you.
Thank you so much. Any comments or questions from the floor? We have some comments on the chat. We are trying to reply that. So I'll thank everyone. Thank you so much. Thank you.